Welcome to DDU teaching. We'll, as I say, focus on cases. I think, I apologize. I think this week they are a little bit hard towards the end, but that might be a good thing to get some practice in with difficult cases. Just to mention, with these cases, we're not obviously going into doing a lot of teaching around them, but I was reminded last week, like when there was the LV aneurysm, like important things about like differentiating between LV aneurysm, pseudoaneurysm. It's obviously clinically usually quite clear because the pseudoaneurysm is essentially a contained rupture, and they're usually pretty sick. It's often catastrophic at the time. And then what was the other thing? I think there were a few. Oh yeah, like how to like how to go through and like look for LV thrombus and how to do contrast and things like that. We have got some summary notes that we'll put a link to maybe in this talk, just going through those post MI complications. So yeah, if you want to look at some extra do some extra reading in the background, we'll pop the link in this week. But let's get on with these cases. As always, ask questions at the end, but I do want people to practice the Viva technique. So yeah, if we can try not to interrupt as people are going through. Please just volunteer. On the day you'll be asked to sort of read out the stem, so let's do that as well, and take it from there. Volunteer for the first one. Again, as always, let me know. I can chop it out. This doesn't have to go anywhere apart from on this session today. So yeah. They do get harder as we go on, so
I can go if you like.
cool. All right, let's do it.
So 82-year-old female cellulitis and hypotension. Cellulitis improving, day 5 ICU with persistent vasopressor requirement, NORAD at 12 mils an hour. Past medical history of DVT, hypertension, diabetes, and glaucoma. All right, so parasternal long axis. The standout feature to me in this imaging is that the LV appears hyperdynamic. The imaging appears like it is on axis. Yeah, the LV is, I'd like to see that in other views. The RV is dilated, the RVOT. It's much larger than the aortic root and left atrium. Just looking at the color Doppler imaging, it's quite difficult with the frame rate. It looks like to me that there's some mitral regurgitation, and I need to see in other views to quantify. I can't see any flow acceleration across the LVOT, but with the 2D imaging, it looks like it would be more mid-cavity anyway. Okay, so this is parasternal short axis view at the mid and basal level. We're confirming that the RV is dilated, and there is evidence of both systolic and diastolic flattening of the intraventricular septum consistent with RV volume and pressure overload. Yeah. So this is so the standout feature in this parasternal short axis, focusing at the pulmonary valve RVOT level, is that there's a suggestion of an echogenic mobile mass at the branch of the pulmonary trunk, which would be consistent potentially with a pulmonary embolus. It would be consistent with the findings so far of the dilated right ventricle. This next image is color Doppler over the tricuspid valve, which is showing probably mild tricuspid regurgitation at this stage. So it'd be good to put some continuous Doppler across that valve and to quantify the right-sided pressures. So this is, again, it's focusing on the right ventricle now, but with color Doppler across the tricuspid valve. There is some tricuspid regurgitation with the frame rate. It's quite difficult to quantify based on this imaging alone. What I can see though is that the RV is dilated. It looks like it's larger than the left ventricle in terms of its basal diameter. So that'd be severe RV dilation. And again, it appears like there's preservation of the apex, which would be the McConnell sign. This is continuous Doppler across the tricuspid valve. The pressure gradient has been evaluated as 40, and I think that's an accurate measurement based on the Doppler trace. So 40 plus right atrial pressure, it's going to be elevated. Elevated right-sided pressures, it'd be good to look at if this is a spontaneous breathing patient, the IVC. This is pulse wave Doppler through the right ventricular outflow tract. Now, unfortunately, it's suboptimal spectral Doppler trace, but it'd be nice to evaluate the pulmonary acceleration time, which I suspect will be shortened, but you can see that there is mid-systolic notching of the RVOT trace, which is consistent with increased pulmonary vascular resistance pre-capillary, which is what you would find in a pulmonary embolus. Now, there's significant respiratory motion artifact, so this is a difficult image to evaluate. I think what I can say, though, that the longitudinal function of the RV based on subjective analysis is impaired. It'd be nice to see that in greater detail, though. Can't really get much more out of that.
Nice, Rob. That's just a zoomed, we'll stop it there. That's just a zoomed up image of that, the branch of the right and the left PAs, which you already spotted on the zoomed out view. So that was really good. Nice job, Rob. I thought you did really, really well. So this is a case of, yeah, an acquired PE whilst in ICU. I think you got all the pertinent features. Dilated right ventricular outflow tract. Yeah, maybe slightly low parasternal, but yeah, normal / hyperdynamic LV function, but no obvious flow acceleration or sort of SAM that you could see. There's some mild MR, and then flattening throughout the whole cycle, consistent with, pressure, severe pressure / volume overload. And then you noticed this, which is really the key thing to recognize there, because it's not often I put this case in not because it's a particularly exciting PE case, that the images are not great, but it's not often we see clots in the in the main PA, which we can see here. So well done for spotting that. I think I'm not sure everyone would have necessarily spotted that. Yeah, and then some mild to moderate TR. It's quite brisk IVC flow, which we can see here on this off-axis site. It's difficult to comment on our RV size here because you're completely foreshortening and making the RV look massive. Sure. But the TR looks mild, but then you've got this really brisk IVC flow coming in, which I think could confuse people a little bit. Yeah, elevated pressures, but less than 60. But there probably is some chronicity to this lady's pulmonary hypertension as well. I think she ended up having a history, sort of CTEPH and with previous DVTs and things like that. This isn't great. I agree with you. None of this imaging is particularly nice, but it's often what you get. Maybe there's notching. I definitely want to see that again in more views, but it does sort of fit with what you've put together on your 2D assessment already. But yeah, you wonder whether it's not quite catching it right and you're slightly obliquely cutting through and maybe you're faking a little bit of the notching, which is, possible. But yeah, it all kind of fits with a sort of precapillary pressure loaded right ventricle, probably from a PE. So what would you like to do next for this lady, Rob?
In terms of imaging or management?
Both.
Yeah, sure. So I think we've established that there's a pressure and volume overloaded RV, and we've got the likely diagnosis. So we need to commence some anticoagulation and discuss the best way to manage this. So she came in again with cellulitis, so it doesn't sound like there would be a reason she'd be contraindicated to anticoagulation. And then if she's hemodynamically unstable, then we need to consider whether we're going to thrombolize her or what the institution we're in has to offer in terms of treatment of this.
Yeah, nice. In terms of like catheter-directed thrombolysis or yeah,
Yeah,
very good. So like yeah, a PERT team discussion
yeah.
considering all the options, risk benefit. Very
Yeah.
nice. Hi Rohit, do you have a question? Oh, I think you're muted.
Sorry. Thank you, Emma. I just wanted to ask with regards to the notching on the RVOT pulse wave Doppler trace. Is that a specific sign of pre-capillary pulmonary hypertension, or it can be present even in post-capillary pulmonary hypertension? And if it's specific, why is that so?
Yeah, nice question. Um, so what it does tell you is that you've got very high pulmonary vascular impedance. Um, you usually see that in precapillary causes of pulmonary hypertension. So basically all of your groups apart from left heart failure. So it does tell you that there is some form of obstruction narrowing of the pulmonary vasculature, whether that's from, acute causes like a PE or whether that's from chronic remodeling in all of the non-heart failure causes of pulmonary hypertension, where you get, remodeling essentially of your pulmonary vessels, which is a complex process. So it does tell you that you've got, significantly high pulmonary vascular resistance. Now, obviously, resistance is only one part of total pulmonary impedance. You have, compliance, and then you have which is your pulsatile load, and then you have your resistant, which is your fixed load. And together, I guess we call that pulmonary vascular impedance. So it does tell you that there is remodeling, that there's increased pulmonary vascular resistance. It doesn't tell you obviously what the reason for that is, so you need to put that in the clinical context. The caveat to what you said about post-capillary pulmonary hypertension, obviously there you see that a lot with left heart disease, whether that's systolic, diastolic, or valve dysfunction. You often see post-capillary pulmonary hypertension in a subs which generally has no notching. However, there are a subset of patients with post-capillary pulmonary hypertension with their left heart failure that eventually, because of chronic pulsatile loading of that pulmonary vasculature, they develop essentially a precapillary superimposed pulmonary hypertension. You see this particularly in HFpEF patients, I think. There is some literature looking at why that might be the case. And there's some nice work published on this, mainly by Gwazi and sort of Ryan Tedford and groups like that, that talk about this, mixed pre and post capillary pulmonary hypertension. So certainly with left heart disease and post capillary, you will get a subset that will develop notching essentially. So it's not very straightforward. Like you definitely can have left heart disease and pulmonary hypertension and still see notching in advanced heart failure. But it does tell you that there is increased pulmonary vascular resistance. Sorry, very long-winded way to say it generally indicates increased PVR, and you need to work out why that is.
Thank you. Thank you.
Does anyone else have a question on that?
Yes, madam.
Yeah.
I'm Guru Prasad. Yeah.
Hi there.
From India. Okay, I've been watching your sessions. I just wanted to know, on the management part, now when we find a clot in the RPA or MPA evidence, based on that, can we thrombolyze or anticoagulate without a CTPA?
No, I would definitely get a CTPA on this lady. Certainly if she was stable enough, because you want to, evaluate the extent of the clot burden and really confirm the diagnosis. So I would recommend if the patient's stable enough to get a CTPA, and then have multidisciplinary discussions about. It depends on what you've got available in your center, how stable the patient is, what the relative and absolute contraindications would be for the various options. But yeah, I would always recommend doing a CTPA whenever you suspect PE. Echo is not sensitive or specific enough. to diagnose it. I guess you have a very high pretest probability when you find mobile thrombus, and often these patients are more unstable. So sometimes you have to go only with echo, and do the best you can with what you have, when you have unstable patients.
Thank you.
All right, guys, we might move on to the second case. Do we have any volunteers for this one?
Yeah, I'll be happy to.
Okay, thanks, Ewan. Go for it.
Yeah. So 45-year-old with septic shock, enterococcus bacteremia, previous IVDU, and alcohol excess. Yeah, so very concerning TT images based on the clinical history. I see a large sort of mobile echogenic mass in the atrial part of the anterior mitral valve leaflet, suspicious for vegetation. Otherwise, on this transthoracic image, LV function appears normal. I'd like to look at aortic valve a bit more closely too. The RV size looks unremarkable. No large pleural effusions or no evidence of pericardial effusion. Yeah, again, focused view of the mitral valve. Yeah, confirms what we saw earlier. Echogenic mass with independent motion in the upstream portion of the valve. I can see it mainly involving the anterior leaflet on this image. Yeah, okay. So significant eccentric posteriorly directed MR, sort of consistent with vegetation in the anterior leaflet, especially if it's causing things like flail leaflet. Yeah, short axis collar Doppler, again confirming MR that we saw earlier. Moving on to the short axis in the apex, or papillary muscle level. Again, yeah, I think LV function looks normal in this view, but nothing else to comment on here. Yeah, so consistent with what we saw earlier again. So again, a large echogenic mass in the atrial portion, upstream portion of the valve. And the collar Doppler, I think there are multiple MR jets, again, which can occur with infective endocarditis. I'd like to also look at TOE images if they're available.
Yeah, just based on this TTE, Hewan, what do you think the severity of the MR is? And would you like any more information from the TTE to try and help you grade severity?
Yeah. So I think it's likely to be severe MR. Even as an eccentric jet, there's a broad eccentric jet hugging the posterior wall, and there may potentially be multiple jets. And even accounting for the fact that the collar Doppler may be is not accurate and underestimate, especially if it's an eccentric jet. I think there's significant collar Doppler signal extending the entirety of the posterior wall, again concerning for severe MR. And I also think there is feature of a sort of flail leaflet, especially the anterior leaflet on 2D. Other images, information I'd like to know is the continuous wave Doppler and the signal intensity. Again, this could be underestimated in eccentric jet, and the contour as well. So look, the density is probably at moderate to severe category. It's not very significant, but I can see that there's the suggestion of rapid pressure equalization. It's not quite parabolic. There's a sort of rapid upstroke and downstroke, suggestive of high left aortic pressure, again suggestive of severe MR.
Anything else that we can look at with other modalities to help you?
Yeah, and the mitral valve inflow velocity, high E wave, at 1.2. It's at it's 1 meters per second. Not quite 1.2, but quite elevated. Other features I'd like to look for is sort of quantitative measures, but in the presence of irregular sort of regurgitant orifice associated with infective endocarditis, things like vena contracta and PISA is unlikely to be accurate. Pulmonary venous pulse wave Doppler showing systolic flow reversal or systolic blunting maybe is suggestive of severe MR. And I think there is systolic blunting here, but again, with an eccentric jet, look, I don't think this tells the complete picture.
Okay, so you said you wanted a toe of this patient. So here we have some toe images.
Yeah. So that's apical 5-chamber view, so A2 and P2 scallops of the mitral valve. So again, and now I can clearly see vegetation in both anterior and posterior leaflet with independent motion.
In a 5-chamber, is it A2, P2? What else could it be?
Gosh, I'll just be guessing, to be honest.
Yeah, we can come back to that. No, that's okay.
Yeah.
It's a bit tricky.
Again, look, I think this supports the impression of severe MR here. Large PISA radius, broad color flow, Doppler in the atria. The left atrium looks enlarged. It's a bit not typical of acute MR, but this patient may have a sort of long-standing other cardiac pathology to have caused that. Yep. Yeah, so LVOT VTI is 15. So despite hyperdynamic LV, because of backflow into the mitral regurg, the LVOT VTI is low. At 90 degrees, this would be A1, A2, and P3 scallops. Again, extensive vegetations, mainly in the anterior mitral valve here. Gosh, okay. I mean, that's, even just that unsubjective assessment, that's a enormous PISA dome with thick vena contracta. Yeah, so pulmonary vein, pulse wave Doppler demonstrating systolic blunting.
These are the left-sided veins, upper and lower, Hewan.
Yep.
And these are the right.
Oh, sure. Okay, sure. And I think right more convincingly shows systolic flow reversal, probably from the eccentric jet.
Critique this.
Yeah. So again, I'd be cautious about doing these measurements and relying on them in the case of a endocarditis associated regurgitation because of irregular valve orifice. But that aside, from technical perspective, look, to measure PISA radius accurately, you'd like to see the PISA dome and the vena contracta and the regurgitant jet all in the same frame, but that's not the case here. I also think that the radius is an overestimate. And in terms of the, I'd also want to double check the timing. I mean, the timing where you measure the PISA radius should be at sort of the peak of MR velocity. So again, that sort of involves interrogating both the PISA image and the continuous wave across the mitral valve. So double check that. Sorry, I'm rambling a bit. And the measurements we got based on these inaccurate suboptimal images is EROA of 1.3 and residual volume of regurgitant volume of 160 mils. So they are definitely in the severe category. Look, yeah.
Good job. I thought that was awesome. Like you ticked pretty much all the things that we would want you to say, like even critiquing the images without prompting, which just shows that maturity and that you've, had lots of practice, and you've seen lots of cases like this. What features support this being acute, severe MR, Hewan?
Acute severe MR. So, I mean, I guess firstly, the mechanism supported the infective endocarditis.
Yeah.
LV is not dilated and normal functioning.
Yeah.
That also
And do you
supports it.
expect it to, because it's quite hyperdynamic, isn't it?
Yeah.
What would you expect the sort of EF to be in acute severe MR if it was a normal functioning
yeah.
ventricle?
High.
High, yeah, so at least 60, right? And if it's less than that, you would, that's probably an impaired, like intrinsic contractility of the LV, because it's just, yeah, as you said, it's got such low afterload. What would be differentials for a mass like this if you didn't have a stem telling you about enterococcus
Yeah.
health?
So in the mitral valve, these lesions, I mean, broadly, so it could be infective and non-infective vegetation. So
Nice.
yeah, merantic endocarditis, due to if there's an autoimmune disease. Tumors, I think probably less likely. And the mitral valve. So again, I think it's very less likely here, and then and then artifact, which clearly this isn't.
Yeah, nice. You mentioned thrombus there as well.
Yeah, I should have. Yeah.
Yeah, thrombus tumor.
Thrombus,
I think
yeah.
not, infective, non-infective. It doesn't really have a feel for a merantic, but you could say it does look a little bit thick and rubbery, in some of the toe images. But yeah, with enterococcus faecium and blood cultures, it's very in keeping with that. Just critiquing, yeah, I loved your response to, assessing severity. And I think this case really shows why, the guidelines for chronic severe MR really, really don't apply. We can't apply a lot of the things to acute severe MR that we see in the ICU setting a lot of the time, because this is how the jet looks. You can see that really eccentric, as you said, posteriorly directed jet hugging the entire wall of the LA. What's the physical principle causing that, Hewan?
The Coanda effect.
Yeah, very nice. And you can't, you just get lots of Doppler splay, aren't you? You can't even really appreciate the flow convergence and the vena contractor. So it's hard to do any measurements there. As you said, your continuous wave Doppler, because it's so eccentric, you're probably not going to catch it, but you do get the suggestion that there is rapid pressure equalization. You're not quite reaching sort of 5 meters per second on that, but the angle is off. I think you could say I wouldn't trust this measurement. There's fusion of E and A. You don't know where the peak of that
Sure.
E wave really is. It's a bit of a poor trace. You beautifully said, because it's eccentric, I wouldn't trust, that there isn't any systolic flow reversal. It still doesn't mean that there's not severe MR, which was very nice. And then it's really hard to do the quantitative measures, I think, on TTE based on the images that you have, because you can't really see, as I said, the components of the jet very well. The fact that the mechanism and the fact that the LV is small, not remodeled, and hyperdynamic all support it being acute. Yeah, I mean, in the Viva, we might interrogate you about LV walls and LV function, as well as the scallops of the mitral valve that you're looking at. So probably interrupt you a little bit more. So when you're in a 5-chamber, you generally you're seeing A1P1. So A1P1, and then as you come down to a proper 4, then it's A2P2,
Sure.
and then push in further. Where you sort of start to get coronary sinus and things, that's when you see A3P3. I didn't show you the 3D purposefully, but yeah, she's got vegetations on the anterior and posterior scallops. Pretty much all of them, I think, apart from P3 was the only one that was spared.
Wow.
It measured, I think, 1.5 by 0.7 or something, so over that sort of 1 centimeter threshold. Follow-on questions that this is beautiful the way you understood the hemodynamics here without any prompting here on. So saying you've got hyperdynamic ventricle but a low VTI because all the blood's rushing back through the LA. That was very nicely done. And you got that beautifully, often in the 90 degrees, the two chamber, seeing A1, 2, 3 generally. But as you said, many A1, A2, and then a bit of P3, which doesn't look like it's got much vegetation on it. It's very, very nice. Yeah, and you recognize systolic flow reversal in the right-sided pulmonary veins. I thought you critique this very well, really well. It's different frames that the continuous wave Doppler is in. You're at the 3 chamber in for the PISA, and then that's done in a bicommissural, I think. And the timing is really important. And often in a still frame, if we've got non-hollow systolic MR, we're going to overestimate using PISA. And I think you're absolutely right about the PISA radius. You can see how tiny changes in PISA radius can really alter the EROA and the regurgitant volume. So it shows some of the caveats, I think, with doing volumetric techniques and more quantitative things in this setting as well. But I do think you answered beautifully. I think you have enough information. I guess follow-on things might be, how it would alter your clinical management, like what you would, indications for surgery with left-sided endocarditis and things like that, which I'm sure you would be fine answering. Do you have a question there? Sorry, you had your hand up for a little.
In the first loop of the plaques with increased depth.
Yes.
Yeah. I think that one is a mirror artifact, isn't it? Behind the.
Yeah. Yeah, very nice. Yeah, no, we should point that out. Yeah, this is a mirror artifact, I think, rather than a big pleural effusion. You can see the movement of the mitral leaflets here. Yeah, very nice for pointing that out. Thank you. All right, guys, we might move on to the next case. Good job so far.
Can we say papillary muscle rupture as one of the DD here? With that AML.
For the DD?
A differential diagnosis.
Yeah.
Hyperdynamic LV with a long vegetation, does it?
It's a good thought. Yeah, it's a good thought. It would look unusual for it to be like that because you can actually see it on the leaflet tips, which you wouldn't see, obviously, a pap muscle being on there. But yeah, if it extended down into the subvalvular apparatus and started eroding away at the chordae and things, a little bit of pap muscle coming through. It's a really good point. All right, guys, let's move on to the next case. This is a little bit point and shoot. There aren't that many loops. So if anyone wants to practice who's got the exam coming up soon. I think Rob or Haywan, why don't we should we alternate between you two? Because you've got it coming up very soon, and yeah, it's good.
Is my mic working now?
Yeah.
Okay, good. 35-year-old female, short of breath and shocked, intubated in ED, history of mitral valve replacement or TTE windows. Okay, so this is a mid-esophageal 4-chamber view. You can see the mitral valve replacement with significant shadowing artifact below it. It appears to me it's not clear pictures. I'd like to review the history of the type of valve. I can see I can see the heart below, although it does look like a mechanical mitral valve replacement. There's significant turbulent flow through the valve, so it'd be nice to evaluate that further. And there is regurgitant jet, which is paravalvular, which if this was a mechanical mitral valve could be expected. I think this is a mechanical mitral valve. So this is at 40 degrees, so just rotated around. We can again see that there's some mitral regurgitation with turbulent flow through the valve in diastole. Yeah, so this picture, that looks more clear now. So I think this is a bileaflet valve with one of the leaflets not moving. So the one on the more anterior aspect towards the left atrial appendage is not moving, whereas the other valve leaflet is moving. You can see the associated artifact of that mechanical bileaflet mitral valve. Now, I can't comment on the left ventricular function because it's impeded by the artifact. So again, there's turbulent flow through the valve. You cannot see color flow going through the anterior leaflet of that valve. Yep. So this is continuous Doppler with a mean gradient across that valve, 14. So I would say, and what was the heart rate? I didn't catch, sorry. It says 77, so less than 80. So we've got a bileaflet mechanical mitral valve with an elevated mean gradient at a heart rate less than 80 and 2D evidence of one of those leaflets not moving. And so this would be consistent with a stenosed mitral valve secondary to a fusion of one of those leaflets, which could be secondary to inadequate anticoagulation or pannus formation.
Very nice.
So in terms of management, the patient's has come in shocked and hypoxic, so likely secondary to raised left atrial pressure. We need to discuss with the surgeons regarding whether she's a candidate for valve replacement. If this occurred in Darwin and she was shocked, then we would consider a thrombolysis for this valve.
Very nice, Rob. Lovely. You got everything here. It's often difficult when you first come in, at 0 degrees to figure out what type of valve it is. It's a little bit of pattern recognition, but there's just so much artifact, as you say, in the LV. You can't really tell if it's like a single leaflet tilting or whether it's a bileaflet at this stage. It's often not until you come around to 60 degrees that you see the nice sort of bileaflet shape of it. I think you correctly pointed out the turbulent flow through the valve and the likely washing jet. So often with these bileaflets, we have the 3 washing jets. They tend to be sort of narrow with not lots of, there's not lots, it doesn't look really nasty, does it, in sort of earliest? No. They're often fairly laminar. You see a little bit of aliasing at the start of it, but yeah, you can usually tell because of where they are and how they look that they're washing jets. But always important to review that. It's not really telling you much more. And then we get to the money shots, and it's really nice tip and trick to use the artifacts of your friend, essentially. So you want to see ring down, and as you said, you can see that nice ring down of the sort of more medial leaflet, if you like, moving, but that lateral sort of anterolateral leaflet is completely stuck. It did end up, I haven't shown you more images, but it did end up being a thrombus in this patient's case. And yeah, I mean, just seeing the obstructed sort of flow pattern coming through and the high gradients, which, as you said, all fit with a severe obstruction of this mitral valve. And I think your management plan was great, sort of urgent surgical discussion. You can either thrombolize or she can have surgery, or you could potentially just anticoagulate. And it's all about balancing the individual factors for that patient. They're never quite easy to manage, particularly outside of a cardiothoracic center. And there are some things, that you would look at in terms of the size of the thrombus on the valve. There are some studies that have looked at surgical intervention versus thrombolysis, depending on the size of the thrombus and things. I must admit, I can't remember the ins and outs of the literature, but I think if you've got a very unstable patient, you haven't got urgent access to cardiothoracic surgery, and you've definitely got a big thrombus on that valve. You're often a little bit back to the wall, and the only thing that you can do is thrombolize them sometimes and take the risk that you might cause a stroke or embolic phenomena to other parts of the body, which unfortunately happens. All right, guys, final case. And we're going to be on time today, which is awesome because I do need to leave as well. Hey, Juan, do you want to take this one again? This is quite hard, this one, I think.
Sure, I'll give it a go. 91-year-old with strep pneumonia, off vasopressors, but ongoing high oxygen requirement. Maybe has had valve surgery in the past. Ooh, okay. Yeah. All right. So parasternal long axis view. The patient does seem to have an aortic valve prosthesis. I'm not quite sure what type. The opening of the aortic valve prosthesis also appears impaired on this view on 2D, but I like to look at some other views. Also, it's most likely to be a mirror image artifact in the LA. Otherwise, LV function appears normal. Yeah. Oh gosh. Okay. Again, look, I think it's most likely to be bioprosthetic aortic valve. There's no sort of extensive acoustic shadow associated with metal valves. On color flow Doppler, there is a sort of eccentric regurgitation with turbulent flow upstream. I'm concerned about sort of a paravalvular leak with this color Doppler. Yeah. So on parasternal short axis, normal LV function. I can't appreciate any obvious regional wall motion abnormalities. All right. There seems to be a significant centrally directed MR. I think there is most the mitral valve leaflets don't appear to be coapting very well, and I think that's the most likely mechanism. Other differentials, it could be whether this is primary mitral valve disease because both leaflets do appear thickened. Yeah.
Yeah, but I mean, if she gets tubed, she'll be a one-on-one. We have to go. I'll tell our nurse manager now.
Okay. All right. I mean,
tell them this is what we think. Unless the CT shows something, unusual. It's not completely normal. He said, "Is it right?" Which is
Sorry, I'm just trying to mute, but I can't do that. Sorry, Juan.
That's okay.
Yeah.
It might be me. Sorry, there's someone talking in the background.
Oh, is it?
Yeah, I'll talk a bit more closely
No,
to the mic.
It's just.
Yeah. Okay. Look, this is apical 5-chamber view, focusing in on aortic valve. The other valve that this could be is a TAVI, previous TAVI valve. I guess unusual features here: the flow convergence. Sorry, actually, I'll move on. Yeah. Gosh. All right. Sorry, if I just come out of the exam mode a bit. The things I wanted to point out was that the zone where the color changes from blue to yellow seems to be quite proximal in the LVOT, which is a bit unusual. I wonder if it's a feature of the prosthesis that the patient has. From memory, I think the TAVI valves may sometimes have this, and you measure LVOT a bit closer, LVOT DVI a bit like into the LV, unlike the native valves. Yeah, but again, on the other images, I don't appreciate any wall motion abnormalities. Yeah, this is just a decent abdominal aorta, isn't it? Collar flow Doppler across there. Yeah, LVOT diameter of 2.3, Oh, well, very abnormal E to A ratio, suggestive of elevated left atrial pressure and diastolic dysfunction. I mean, E to A of 2.8 would put the patient at a grade 3 category. Okay, again, very elevated E to E prime, well above the cutoff of 14, which is very abnormal, and sort of as expected, E prime are both severely decreased, both medial and lateral. Okay, so the velocity across the aortic valve is increased at greater than 3.5, suggestive of sort of pathologic obstruction. I mean, other differentials being things like patient prosthesis mismatch or hyperdynamic state. So other values I'd like to look at is, yeah, the dimensional DSI. So is 0.4. So look, that's probably not very abnormal, not severely abnormal there. That's a bit reassuring. Acceleration time also can be used. Very short acceleration time can mean it's a pathologic obstruction rather than sort of hyperdynamic state or patient flow mismatch, patient prosthesis mismatch. All right. Okay. Yeah, so look, it's an eccentric jet. Then pressure half time is 260. I gotta think like this in itself is gonna is a reliable marker of aortic regurgitation severity. There's no sort of end diastolic flow reversal in the descending aorta. Gosh, I mean, again, I realized that I probably just in the last 5 minutes, I just instead of synthesizing things, I just talked about what I saw on the images.
Yeah, no, this is a complex case. I think you've done very well here, Juan. So, but try and put it like try and just have a little bit of structure for summarizing the key points.
Yeah.
In the clinical context.
This elderly patient, previous aortic valve prosthesis, and now persistently has high oxygen requirement. Look, I think the salient features that I saw in the echo that I'm concerned about is there is increased velocity across the aortic valve prosthesis, which is, and also very abnormal 2D images across the prosthetic valve concerning for prosthetic valve obstruction, whether that's from thrombus or pannus formation. The other feature, which may or may not be related, is significant diastolic dysfunction and raised left atrial pressure, which can be related to long-standing sort of aortic valve disease or malfunctioning valve. You know, but they can certainly contribute to high oxygen requirement. Aortic regurgitation, again, it could be how does that fit in? Patient may have sort of both stenotic lesion across the prosthetic valve, but also a small degree of paravalvular regurg. But I don't think that's sort of the main cause of dyspnea of high oxygen requirement. Although it will contribute to the raised LAP. So yeah, so those are the things that stand out to me.
How would you like to use what you've found to guide your management in the next few hours looking after this patient?
I mean, so breaking it down, so I'd like to get a bit more sort of history, especially with regards to the valve prosthesis and sort of the baseline measurement after the valve procedure, what the initial velocity was, and what kind of pressures I should be expecting. The other things I would like to look at from diastolic function point of view, what I would do is try diuresis, and if there's an improvement in values such as E to E prime, and the E velocity or decel time. If there is significant improvement, that might indicate that diastolic dysfunction is the main driver of dyspnea. And I think investigation of this prosthetic valve and possible obstruction across it is going to involve, good history taking, looking at sort of other investigation, whether they're positive blood cultures, inadequate anticoagulation, sort of prothrombotic states, any reason this patient might have hypodynamic circulation.
Yeah, very
yeah.
nice. So, Rob, you had your question up for your hand up for a while. So, do you have a question related to that?
I'll let
To
you
this
give your
case?
feedback, and then I'll just make a comment if you don't mention it. That's all.
Oh no, go on.
Oh no, it's nothing to do with Haywan's. I think Haywan did great. I think it's the tissue Doppler imaging.
Yes.
I just the measurement of the E prime is inaccurate on the lateral.
The lateral. Yeah.
And I just
Okay.
wondered, just for both of us, I wondered if, because it seemed interesting that you started showing us all these other images like the LVOT, which also looked like it's inaccurately measured, and wondered if that was why you were showing us these images was because just to comment on how they've inaccurately measured these things.
Yeah, we'll come back to that. I agree with you, but this is often what you get when you're reporting these scans. And you sometimes do want to go back and repeat the measurements, but sometimes you've got this is what you got to work with, and bad in equals bad out, but you've just got to work with what you've got and ignore the things that you think are inaccurate. And there's still a lot of other information that you can use. Yes, this E prime is inaccurate in the lateral side, but it's probably no more than 5. Maybe that's an L wave in the tissue Doppler trace that you're measuring there. And I think the E is next to it, which is probably around 5. Either way, I think the E to E prime is way above 15. Yeah, I'll come back to some of the the E and A ratio and things in this context. But Haywan, I think this was a really complex case. Firstly, it's a 91-year-old. How is this a 91-year-old that's still mowing his lawn, or is this a 91-year-old that's from a nursing home and fully dependent? Because that's really going to drive how much you push this as well. But essentially, he's recovering from his sepsis, but he's still got high oxygen requirements. And what that says to me is his respiratory failure from his heart? So is it cardiogenic pulmonary edema, or is it from his pneumonia? And that's really what I'd be thinking when I was going through the echo. And I think he's got a lot of cardiac causes that could be contributing to this being a significant cardiogenic pulmonary edema. I think he probably does have elevated LAP. The thing that I would want to see on him, which is what we ended up going to do, was lung ultrasound, and he just had B lines everywhere with relatively thin pleura, which did support more of an element of cardiogenic pulmonary edema here. He does have an abnormality, he has a biprosthetic valve, aortic valve. It's we didn't know what it was, what the footprint of the valve was, what the baseline function and everything was at this time. But it's definitely abnormal. There's increased velocity. There is a relatively normal DSI of 0.4, but you're absolutely right to comment on the accuracy of all of that. So let's come and have a look at this. We've certainly got flow acceleration as well as regurgitation, which is eccentric through that valve. Is that new or old? We don't know this at this time. He's not bacteremic at the time, but you certainly be worrying about those things as you mentioned. The moderate MR is significant, I think, in this case, as well as the little bit of mitral annular calcification, because these things are going to impact what I show you with your ENA. So your EA is less helpful when you've got at least moderate mitral regurg, because you're going to get a high E velocity from your mitral regurg, because it's your EA is so load dependent, and that's why you can't fully rely on it when you've got mitral valve pathology or if you've got a normal ejection fraction. However, in saying that, I think you can still infer that there likely is elevated left atrial pressure with the intraatrial septum position, the lung ultrasound showing B lines everywhere. And I think that's where lung ultrasound really becomes helpful here. You could interrogate his pulmonary veins as well, and just obviously the mitral regurg is going to impact on that. But this is real life assessment of diastolic dysfunction in the critically ill. They have a bit of pathology here, they have a bit of MR, a bit of MAC. Like this is just the real, life difficulties in non-invasively assessing left atrial pressure. And to be honest, you just have to look at the trends, do diuresum, see if it comes down. In fact, he went to a more impaired relaxation pattern once he was diuresed and his LAP came down. If I had time, I would have showed his repeat imaging after diuresis. Yeah, the decel time isn't particularly restrictive here, is it? 255. We normally sort of say less than 160 would be that sort of really restrictive inflow pattern. But he certainly responded to diuresis with his EO ratio coming down to an impaired relaxation pattern. So if you've got moderate MR, you can still use your E to E prime of more than 50, more than 14, I think. But it's better if you've got a reduced ejection fraction. So in those with reduced ejection fraction, even if you've got moderate MR, your E to E prime is usually relatively good at telling you you've got raised LAP. But yeah, I think you just have to look at other things in this particular case. But coming back to the valve, which is where I think obviously there's concern about the valve as well. You're absolutely right. You need to look at all of the previous things. But let's have a look at some of the values. So let's just come to this one. Remind yourself of this. So if you've got peak velocities across a prosthetic valve of more than 3 meters per second, you've got to think about, could there be, potential pathology with this valve? The dimensionless severity index, or DVI, dimensionless velocity index, is helpful. Obviously, if that's less than 0.25, that suggests either you've got significant stenosis or you're measuring things very incorrectly. And the accel time, I think, is very, very helpful in this circumstance and what the contour of the jet is. His is just borderline, isn't it? So I think you might have said a short accel time here. One is suggestive of severe stenosis. It's not, it's a long accel time, right? So the more parabolic and rounded it is, the more likely it is to be stenotic. So if you've got someone with a high velocity, DVI less than 0.25 with a really rounded parabolic jet, like that's stenosis severe until proven otherwise, right? In him, it was a bit tricky. So his DVI was 0.4. His accel time was borderline, like 96 milliseconds, so almost sort of rounded. And you did get the idea in some views that maybe he did have some subvalvular sort of narrowing, and you noticed that he did have that proximal flow convergence in his LVOT, and it did look quite narrow with that sigmoid septum as well. So maybe that was contributing to what was happening with his gradients. But if you follow this, you'd come down into this sort of area of the algorithm. And his EOA indexed came out at 0.96. However, that's using an LVOT VTI, which is imperfect diameter, right? An LVOT diameter, which I don't think is quite accurate. You can see where that, they say to measure where your prosthesis inserts into the septum at that sort of joint, and then where the prosthetic ring suture sort of inserts into the anterior mitral leaflet, and to measure it there. And that's where you should do your LVOT VTI sampling, unless you've got significant proximal flow convergence, which you have, and which can compound things further as well. So sometimes measuring further back to try and match up where you're doing your VTI for the continuity equation is helpful. So I think where they've sampled is slightly in the proximal flow convergence. So we're likely overestimating the VTI a little bit. But don't forget, there's probably moderate aortic regurg as well, which is going to contribute to some of this, which should be corrected for with the DVI. So that's why I find the DVI a particularly helpful number, because it's flow corrected. Essentially, it's not flow dependent. So I think, the DVI of 0.4 was slightly reassuring to me. And then putting that together here, we felt that he probably had a degree of patient prosthetic mismatch, and that things were exacerbated by his high flow state with his recent sepsis and pneumonia, and maybe a little bit of subvalve narrowing, but nothing that we could see massively significant. Yeah, you definitely need cardiology input with these. You need someone that knows, is very experienced with these things and knows what they're looking at. In the normal setting, we'd go on to do, TOE imaging, because you can't get a proper look at the valve so you want to really interrogate that valve with transesophageal echo, as well as maybe get some more TTE images. And sometimes other imaging with CT as well, multimodal things can be very helpful if you're not getting your answers with echocardiography. So yeah, it was a difficult case, this one. He actually was a very, very frail, this man. And we ended up just diuresing and repeating his TTE, and his gradients did start to settle down, and we just sort of decided to keep an eye on it that way, and treat his pneumonia. And as I say, his diastolic dysfunction and LAP side of things got better, and his B lines disappeared and things. So I think it just shows, obviously, we need to integrate what we're finding in the clinical context. Everything's individualized, but I think the echo did help his management. And then it's about trending, right? So choosing what you're going to do, and then instituting that, and then seeing how that your treatment impacts the parameters that you're seeing. And that's the end of cases for today. We ended the difficult one. Yang, who's the head of exams, is going to be taking some vivas next week. So hopefully you can join in person. If not, we'll obviously be recording it. So do catch up with that one. Does anyone else have any questions about any of that or any of the cases? Cool. Thanks for joining, guys, and we'll see you next time. Thank you.